All right, we're live.
All right, good morning. It is February 24th. This is the Senate Health and Welfare Committee meeting. Thank you all for being here. And I see that the Agency of Human Services is represented. And Lori, I know you're here, and we are not getting to gubernatorial appointments until 10 o'clock. Yep, 10 o'clock. So, okay, just to FYI that. For Mike Smith at least, but Mark Levine will be at 9:30. We had a little bit of time committee this morning, and I thought it would be helpful just to have a committee discussion. I wanted to bring you up to some of the thinking that's going on around moving House bills forward. I think it's really very important for us to focus on the House bills that we have gotten or that we will get, and knowing that the big bill is the child care bill. And so we're going to spend, as we did the last time we had the big child care bill, we spent a couple of weeks on it. So we're going to have to look forward to that. It's a good thing. The other issue that is kind of percolating under everything, of course, is the discussion about our all-payer model and the waiver, global commitment waiver. So I'm bringing folks in over time, beginning this week, to bring us up to date on provide information about the Next Gen program, where we are, and try to understand a little bit of what's going on. My concern about healthcare reform overall is probably shared by everyone, but I think one concern that I have is we don't want to let the discussion happen out in the press. The discussion needs to happen here, and we need to have all the data in front of us. So allowing for controversy to move ahead for whatever reason, doesn't make sense. I think I will be sending out to you a link to a report that was done on the first year of the Next Gen all-payer model. It was done by Medicaid and others, and I think it will help identify some of the issues and concerns and questions that we want to ask as we're looking at the reports that are coming into us, or the information that's coming in particular, as we hear from the Green Mountain Care Board and Ina Backus. So we'll do, that's on Thursday. So I will send that out to you, the link out sometime today. I have it ready to go. There will also be other information that we can access that will maybe help at the fundamental level, at the ground floor level. I haven't asked Jen yet to come in and talk about the statute related to ACO. I'm not sure that's necessary, but we might do that. So just to let you know, over the next couple of weeks, we'll be gathering information about what is happening and what has happened to help us get all get to the same page, possibly, never know. So that's one. And so we'll do what we can do. I know that we will have at least two bills in our committee. We have more. I know there are lots of bills in about changing the way we pay for health care, changing the way people access health care. So we need to pay attention to all of those areas. I want to say, from my perspective, what is absolutely key is having prevention and primary care be primary. And so we've talked a lot about how to maintain our primary care practices across the state. They are absolutely key to ensuring that the current healthcare reform goes forward. And I would say they're probably key. Primary care is probably key to any of the reform that we do. But then allowing for folks to have access to primary care without significant or any co-pays. So that's an area we really need to pay attention to. And we can't have a robust healthcare system without ensuring that our providers are there and are reimbursed equitably. So this Friday, we'll be beginning to look at a report from the Green Mountain Care Board that discusses provider reimbursement, and that it extends from hospitals to DAs and SSAs. So it was a report we asked for. It's a little bit complex, as I said yesterday, but we'll look at that. Having a link between hospitals and designated agencies through care management process is something that we see as critically important. So folks in primary care, folks in acute care, in primary care, being part of a medical home team, a medical home, and having access to the services that they need that might be in the community. So a continuity of care, which is integral to much of the reform that we've been looking at. But when we talk about that, we're also talking about significant resources. So care management resources, financial resources that are so important to maintaining that system of care. So there are a lot of things I think in the plan and in the principles that went and thinking that have gone into our healthcare reform, and we want to be sure that we keep the good things in place, and that we also respect the process that is going on through the Agency of Human Services, the federal government, our waiver, and the Green Mountain Care Board. So that's just a little bit of the thinking that I've been doing, and I think from my understanding, at least, I think you also are thinking about some of these things. So, and as I said, we'll be putting, in addition to what we'll have on our agenda this week around hospital financial stability and maintaining our hospital network, because we do know that many of them have been in the red and have drawn concerns as a result of the pandemic. We want to make sure that our other providers are held in good stead so that patients have access. And critically important is reducing the cost of care. So it's this balance between providing financial stability and reducing costs of care that we'll continue to struggle with. But I think this is a challenge for us. And as we look at our different bills coming to us from the House, and we look at some of the bills introduced here in the Senate, we may be able to make some recommendations going forward that allow for us to gather information, or to make some discrete changes, or some more high-profile changes. You never know. That's it for me. I just I did feel I needed to share that, and I will send some information out to you that Joint Fiscal has done, or that Medicaid, Corey Gustafson has done. So, and we have Green Mountain Care Board coming in, and we will have others coming in. So, and I know you have suggestions of who you'd like to hear from as we get more drill down further into the bills. So I look forward to that. Oh, comments, questions?
I was unprepared for this conversation. I'm not sure what
No,
what the goal is, so I don't know.
The goal is
no comment at the moment.
That's fine. The goal is to give you some information about the direction the committee is going, and I know that healthcare reform has been on everyone's mind, and I saw an opportunity for us just to at least for me, to share what my thinking is. And I will continue to do that as we go forward. But so the bills that we looked at yesterday, the House bills, are there any priorities out of those House bills that you've thought about since yesterday? So I will begin to schedule those, and I do have, we also have some Senate bills that we're very interested in, so. Any thoughts on any of the bills that we've looked at? I know the H430, the Dr. Dinosaur bill does have some resources in it. We'll have a fiscal note. The Health Disparities bill, Health Equity bill is what its proper name is. Any thoughts on any of the bills that you would like to look at first? Go ahead, Ruth.
Well, I mean, I think they all have promise. I'm really happy to see that our counterparts in the House have been doing such good work. And, you know, it's it's a little overwhelming because there are 2 committees over there that send us bills, so we get double the bills. But
we're twice as good. We work twice as hard.
Yes.
Yeah. Okay. We got
there
it.
you go. The child care bill is obviously a priority of mine, and looking at that, taking our time and due diligence with that bill to make sure that we get a really solid plan moving out of the Senate. And I think the House has done a really great job setting that stage. And I'm really interested in working on H430, that undocumented immigrant bill for mothers and children. That's a big issue in my district, with a lot of migrant farm workers in Addison. There are also obviously immigrant populations in other parts of the state too. So that is something I'd really like to dig into. And I think there are a couple bills. The Health Disparities bill, I think, obviously is important. It's hard for me to say that any of these are not important. They're all important. I also hope that we take some time with the mental health issues, and especially coming out of COVID. And we heard some testimony on that, but I think mental health is an area that deserves more attention than we've given it recently. Yeah, I mean, I think they're all important. I hope we can find time to do them all, but I guess those sort of float to the top for me at the moment.
I couldn't agree with you
we
more.
haven't gone through all the bills, so I don't know all the details yet, but.
Yes, that's our next job, I think, is to invite the reporters of the bills once we get them. We don't have all of them yet, but we do have some of them, and to invite the reporters in to provide their information and then go through the bills with Ledge Council. I couldn't agree with you more about the mental health issue. And as we're looking at that bill, we will hear from DMH on some of the things that have been going on with the Middlesex facility and the possible new secure facility. And so how that's playing out, what the programmatic changes may or may not be. So that's an area that we need to pay attention to. And then not the least of which, of course, is the significant mental health needs that have arisen as a result of COVID. And we may be able to look also at that point on some of the substance use disorder issues that have been exacerbated as a result of COVID. So there's a lot there. There's a lot there. Senator Hooker.
I'm just thinking that it seems as if, the mental health issue and funding for the DAs and SSAs have a connection that, we need to keep in mind, because these are the organizations that are giving the services and, in the communities. And so That's important.
Yeah,
And
you're right, and it gets all tied up and wound up in sort of the base pay issue
Mhm.
and the reimbursement issue that we're going to be hearing about.
Yeah.
You're right. So, and
And
then go ahead.
I've talked to some child care centers, parent-child center, and need to really look at the funding that's coming for childcare, because there are some services that they want to make sure are maintained. And I don't know, we're going to deal with this a little bit in education as well, about the kind of restructuring of that whole childcare system for preschool and the like. But it's complicated, Senator Lyons, as you're fond of saying.
Everything that we do is, but I think, we really do have a bead on the importance of childcare in this committee, and sort of maybe some of the structural changes that might be needed. But as we start looking at the parent-child center bill on Friday, that's one of the reasons I wanted them to come in early on. And Ruth is the lead sponsor on this bill. It would be, I think, very helpful to get the sense of how they fit into this whole the area, not just of childcare, but also of primary care for kids. So it's a whole big area. And what,
Ginny, related to that, I'm sorry, did
No,
you
go ahead.
want testimony on Friday, or we're just doing a walkthrough, right? We're not starting testimony on that bill, are we?
Yeah, we can talk about that later, but it might be helpful to have a couple folks in. So
Okay.
yeah.
Because related to that, I mean, Senator Hooker's right. It's the parent-child centers are related to the child care bill and also education, and they sort of fit this, and DCF services, and they're kind of in this nook in between all of those things. And I've recently heard about some issues with transportation. I don't know if Cheryl, you're hearing that as well. You're nodding your head. So that's another issue we'll need to dig into, related to the parent-child centers and what's the status of that. Apparently the House has made some changes there. And the other thing is, I just was looking at my list from yesterday. The home health services bill is also an interesting thing, I think. Long-term care in our communities, whether it's in our homes or in facilities, is an area that I've recently had a lot of experience with, and it's a really complicated and expensive web. So I think spending a little time on that as well.
Yes, and as we look at one of the things that we did last year was with the Older Vermonters Act, and we should go back and look to see if the plan is in place and how the state plan looks, and that might lead us into some further areas. There is a lot here, so I am going to put a number of these bills on our agenda with the sponsors, and possibly with some introductory testimony. I think it's important that we just work along through as many of the bills as we can, and then we'll take a stop and we'll dive into each one going forward. So, but first we need to know what's there and which ones we want to really pick up first, second, third, and so on.
Yeah, because it is the first year, so we can.
Oh yes.
It is. Another bill that I wanted to ask about, that I don't know if it's actually been introduced on the Senate side this year. We certainly could do it, but is the bill about hearing aid coverage for hearing aids.
Yeah, that's
services for the deaf. I remember I actually was a co-sponsor on that bill last session, but it didn't get picked up again this year, and someone just asked me about it.
Okay, so Senator Ballant and I have had this bill sitting there ready to be introduced, and I have to touch base with her. But you're absolutely right, Senator Hardy. There's nothing more important than trying to get hearing aid coverage for folks, particularly now. So I'll circle back with that, and certainly welcome to be part of that, signing on, sponsoring it. That'd be great. So
yeah, that'd be good.
Yeah.
After my ENT appointment yesterday, I was surprised to learn about a law in place in Vermont that mandates a 60-day trial period for people who are checking into hearing aids, which I found very reassuring.
Yep.
Since at some point, I'll probably, and I'll wait until the bill passes before I go and get a hearing aid.
There you go. No, it's interesting because so I know someone who did go for a hearing aid and was thought that the retailer was so wonderful for allowing the 60-day trial period. And so I said, no, that's part of state law. That's good. Josh, anything you want to add here?
No, I think it's been good discussion. We have plenty to work on. And I know that, a few of us are pretty passionate about looking at that ALS bill at some point. So.
Oh, yes. Listen, I'm glad you brought that up because I had a communication over the weekend from someone who lost her husband to ALS 2 years ago. It's someone I actually know. And I did not know that he had died because of ALS. So, if we can do S90, that's S90, I think. If we can get to that bill, I think that would be a really important bill to take up and to pass to the House. If we can get dispensation to do that.
Yes,
And
agreed.
I know, yes, so we can talk about that one as well. It is a huge concern in our area. I'm talking about our state.
Well, it seems like the data says there's only 6,000 new cases a year, but it seems like every time you turn around, you know somebody that's been touched by ALS, and it's much more prevalent than I think that people believe it is. So,
well, you've just touched on a pet project of mine, and I think everybody else on this committee. So we'll see what we can do. If we can get some testimony and take it forward, and we'll ask to allow for that to happen. I think that would be a bill worth working on. I agree with you. I hope, I don't know, I see the other members of the committee sort of shaking their head yes, so I hope that's agreeable. Who knows? I mean, it's all dependent on the time that we have. So, but we'll see what we can do.
I mean, the bill it's just a registry, right? For people who have ALS. Is that, I mean,
yes.
I don't mean to belittle it, but meaning that it shouldn't be highly complex, hopefully, knock on wood.
Well,
so
you understand that the Commissioner of Health is now listening in to us, and he may have something else to say about the complexity or the lack thereof. But and eventually we'll get to testimony from the Department of Health on this. I don't know what the thinking is there, but I think there are a lot of people who think it's necessary. So committee, thank you for this. I will send out the early report draft, early report, not a draft at all, on the next gen the all payer program model, so that you can read it, and then maybe some other information that reports that we've had on our healthcare reform process. All right. So Commissioner Levine is here. I can see that you're here. Commissioner, are you? There you are. It's very good to see you.
Good to see you all.
Well, good. Thank you for being here. So as one of the many responsibilities that we have, it is to confirm the folks who are recommended by the governor to serve in various positions. And this is your confirmation hearing for Commissioner of Health. We have received a letter from the governor, and so it's really an opportunity just to hear from you. And I guess what would be helpful is a little bit about your background, who you are professionally, and then what you have seen as the greatest challenge. We can't imagine that there would be a challenge in your position, but what you've seen as the greatest challenge, and then what you are looking at going forward as critical for the Department of Health and more broadly for the public health of the state.
Is that all?
No, just a couple of things. And we do have a half an hour. So, I mean, if you can spend a few minutes on the things that we've talked about, and I'm sure there'll be questions from the committee as we go forward.
Sure. So, I look at the screen and this is such a different committee than it was before.
Yeah.
So I will give a little bit of the reprise about my background.
So I don't want to stop you right in this beginning, but Senator Cummings is unable to be here for a personal reason, but she is a continuing member of the committee. Just wanted you to know.
And so I'm sure with her crystal clear memory, she would have remembered everything I'm going to say about myself. So I became health commissioner in March of 2017. And that was a rather late in career pivot for me. I began as, let's see, well, I'm an internal medicine physician by training, general internal medicine specifically. Most of my career, I've considered myself to be what's called a clinician educator, an academic physician who does minimal amount, but some research, a lot of teaching, a lot of administration of educational programs, specifically directing the internal medicine residency at a place in Pennsylvania originally called Geisinger Medical Center, which is a multi-specialty clinic modeled on the Mayo Clinic. And then back in Vermont, where I had originally trained, at the University of Vermont Medical Center, then called Fletcher Allen Healthcare. The career evolved to directing all of the postgraduate programs, residencies and fellowships at UVM, and becoming an associate dean for graduate medical education. So always been involved a lot with both undergraduate and graduate medical education, running programs, teaching a lot, but always maintaining a practice as well, and seeing patients in a general internal medicine mode. Originally for many years, both in the hospital and in the clinic. And then in later years, when the hospitalist movement came about, spending more of my clinic time with my patients and sort of covering nights and weekends in the hospital, and then eventually becoming all outpatient towards the latter number of years. I also did a fellowship in general internal medicine at the University of North Carolina at Chapel Hill, where I picked up a lot of my research background, clinical epidemiology, and a little more on teaching and administering programs, other professional responsibilities. I pivoted to the health commissioner role when it became available and when it was put in front of me, but that had been the culmination of a number of years of working in what we call the Primary Care Public Health Integration Working Group, which still exists. It's a group between the leaders of specialty societies across the House of Medicine with the health department. And I originally got in because I was the leader of the American College of Physicians chapter in Vermont. ACP is sort of the internist's professional home. So that's where I have spent a lot of my professional time as well. And so I became well known sort of in the public health circles just because of my involvement in that working group. But as my career evolved, I love medicine, love patient care, cherished those moments where I could advance people's lives in good ways in terms of improving their health, but also improving their lifestyle behaviors, because really one of the major determinants of overall health is the way we live our lives, as we all know, and those are the hardest things to change. And if you think about it on an individual basis, it's even harder to change. The successes come. Sometimes they come within weeks. More traditionally, they come within years or even decades. But that's why having a longitudinal relationship with your patient population is so critical. But I became more interested in the impact of public health and population health and how I could actually favorably impact populations at large as opposed to one-on-one in my own office setting. And I especially, and this committee has been so helpful in this regard, viewed the role of health policy as it impacts that sort of nexus where health, healthcare, public health, and population health all meet. And that's really how I see my position now, is sort of trying to represent that entire umbrella and nexus of all of those entities together and do good things. And thanks to the leadership in your committee and the tradition of the committee, a lot of good things have happened even in my short tenure, which we all regard in a very positive way in terms of vaping and smoking and the restrictions that were put into place regarding them. We're doing a lot of work with environmental health, and the bill with the lead in school drinking water comes to mind with that regard. So really, it's an opportunity to really have a much higher level impact, if you will. Doesn't detract from my affection for and frankly missing the interaction with patients one-on-one. I wish there were time to do everything in this job. That would be ideal. But at the same time, my familiarity with that setting and how we can favorably impact what goes on in that setting has paid dividends as well, because I have great relationships with the academic community, with the medical society, and other organizations across Vermont that all really want the same things in the end, and it takes a village to get them accomplished. So that's my background, and sort of my view of my role, if you will. I'm so honored to be able to lead a department like the health department because I say this in a positive way. You couldn't get more do-gooders in a building than you can do in the health department. I mean, nobody comes into that kind of career, especially at the prices we pay in Vermont, salaries we pay, if they don't have this overwhelming dedication towards improving health and improving the stature of our state with health and the public. So there are so many things that our society writ large across the country, sometimes across the world, have not paid attention to, that we can actually put the spotlight on and do important good things in. And if there's one thing the COVID pandemic has taught us, you do not have to compromise public health to have economic health, nor vice versa. And we should remember that lesson because we've done it. We've reopened Vermont, and though no one is satisfied with where we are economically, we're pretty much up there in the highest echelon of states for how we've done. And if you put us next to South Dakota, which actually, from an economic standpoint, is standing at the same place we're standing now in terms of the recovery of its economy, 80-something%, they actually chose to ignore the pandemic and not put public health on a pedestal, if you will, and not value it to the degree Vermont has done. And you can see the differences in our rates of hospitalization, our rates of death, our rates of cases. God knows what else we'll see the metrics reveal. And so at what price? They still ended up with the same in the same economic place we're at. So I use that as an example, not to dump on one state particularly, just to show that you can actually do a lot together. And that's really important because I think the Health and Welfare Committee, the legislature at large, have to prove that every day, because there's always concerns when we bring something up about the dollar price that's attached to it. What's that going to make us not do if we do this? And a little more reluctance, not just determined by term length. I mean, no, it's really determined by the way everyone looks at life. People don't look into the future to see the impact, the return on investment over the number of years that are required. And what we've learned, and what I learn every day, is return on investment is not a 10 or 20-year proposition. It's often within a year or two. And you can start to see those impacts. You may not see the full impact, but you start to see those impacts already. So I'm going to leverage this pandemic as much as I can. I'll be very frank about that, because we have learned so many lessons. I give so many talks about, what have we done? What do we do right? What are the lessons learned? What were the controversies? But the bottom line is we should remember some of these lessons and what we got accomplished, and apply them in our future thinking when the pandemic is hopefully in the dust and behind us. So keep that part in mind. You wanted me to address a little bit about my background, what I see for the future, which I'll get to next, but in the middle, what was the second?
I knew that was going to happen, so no apology. It was a memory test. I'm just kidding. I think maybe a few minutes or just a few sentences about the challenges that you've met and what's been really most difficult during your tenure as commissioner, and then I think most importantly, how you're looking at the critical issues for the future.
Okay, good. So my challenges, we'll start with just during the pandemic, because that's a full year already of my tenure. And that's just amazing in itself. It's actually more than a year, because we were organized way before the first case. And now we're stretching on past a year. So it's really hard to prioritize anybody. And the minute you do, you've created inequities, even if they're well-intentioned. So here we are, we were full into our vaccination efforts, but, we've had to be very steadfast about preserving life is our goal. And if preserving life is our goal, we're going to use public health data and population-based data to show us the roadway, the pathway. So what we've done is, as you know, done the age banding, looked at high-risk conditions. But as you know, there's 1,000 other people who feel that they are deserving of being in the front of the line, whether they work in a grocery store, whether they're in the education system, whether there's some other, quote, essential worker, of which 85% of workers are essential workers, it turns out, or whether, as I found out in my meeting this morning with the Social Equity Caucus, whether you're in the BIPOC community, of which there's a compelling reason for them to be at the head of a line in many ways. We had a great meeting, by the way, so that was the good news. And I think we see things in the same way now. But those are the challenges, trying to really advocate, as I'm supposed to, for every Vermonter. The mission of the health department is to promote and protect the best health for all Vermonters. Well, by definition, when you start prioritizing people in a vaccination effort, it's a little hard to do both at the same time. So that's been very challenging. And to have to say no to so many people, which is not what I'm accustomed to doing, for sure. So that's a challenge. Another challenge during the pandemic has been really how onerous it is on the population. So making sure that when we create the levels of restrictiveness, we understand what that impact is on the person on the street, no matter who they are. And That one's turned out to be a better challenge because people are actually appreciative. That wouldn't be true in every state in this country, but in Vermont, the majority have been appreciative of what we've instituted because they too look at the data and see how our data is so different than other states that they've compared us to. So, but that's been a big challenge, to say the least. Another challenge I'll be very frank about is, we have several branches of government and they're not always aligned in what they want. And I get sort of pointed at as being part of one branch of government, which I guess I am, but I try not to be, political in my job, and keeping the politics out of it is very challenging. Fortunately, I'm working for and with a governor who whose desire to preserve and promote health and public safety are paramount to him, even more so than the economy. And we all know his background and how it pains him when anything about the economy is suffering because of the pandemic. But he's been very much aligned with putting public health and public safety first. And over the time that I've been health commissioner, that has been true as well. And, many of you know when the governor doesn't align completely with the things that you want to get accomplished. And I have to sort of dance a dance in between some of those extremes. And I can be frank, you asked for challenges, those are challenges. But I have to tell you, when it came to vaping, there was no challenge. It was like the governor was like, we can't let these kids suffer in the way they're going to suffer the rest of their life. When it came to the lead in the drinking water, it was like, it's going to cost money. We're going to have to talk to the legislature, but how can we not pay attention to this data? It's too compelling. And if there's any toxin that we know a lot about and its effect on the brain, it's lead. So we've got to talk about that. And even now with BIPOC, there were obviously a lot of people who wanted us to move BIPOC to the front, period, because of historical injustices and systemic racism being such paramount matters now with George Floyd and all of the national publicity. But the reality was, if we were going to stick to our preserve life and age banding philosophy, we couldn't put all of BIPOC at the front of the line as consistently. But I think we found a nice sort of even ground where we're allowing a multi-generational household to all get immunized, knowing the high risk factor that population has with multi-generational households causing even more of an outbreak for them. So that's worked out well. So there's a lot of challenges, needless to say. The challenges really in public health are that so many of the problems are not new to us. We try to make them not new to anybody else either, but they are new to many other people. And we know that they're going to take a long time to resolve. And trying to work through the slowness of the process sometimes is challenging. Sometimes when something is a big, high publicity item, it gets you get there pretty quickly. But even when you look at those items, there's a slowness to them because you can't overnight change everything. We have a 3-4-50 campaign, which is really, the 3 bad behaviors: poor nutrition, no physical activity, smoking, that lead to the 4 chronic diseases that are most prevalent, causing death in Vermont: heart disease, cancer, lung disease, and diabetes. And they cause over 50% of the deaths, 56% of the deaths. So you'd think, oh, if only people would just pay attention to those 3 behaviors, life is good. Well, it doesn't work that way. And moving that needle takes a long time. And we've worked with organizations like Rise Vermont to try to get more traction. And the governor has been very positive about that. But the reality is that's not going to happen overnight. Whereas something like changing the smoking age to 21, you've made an overnight decision that is going to have a huge impact on a large population of adolescents, which is a much quicker turnaround. In terms of my view of the future, Once we get through the pandemic, we're frankly going to have a small group in the health department that is COVID, part of our health surveillance group, which pays attention to so many other diseases, whether it's tuberculosis, HIV, enteric pathogens, tick-borne and mosquito-borne diseases. All of that occurs in health surveillance. But right now, pretty much all that occurs is COVID. So the goal is we'll have a special division of that that's COVID related, and we'll manage COVID for God knows how long, because it's not going anywhere. In spite of our successes with vaccine, et cetera, it'll still be around. But that will free up the health department, who's really been working on multiple jobs at once, but everybody, all hands on deck working on COVID, to return to all of the things we want to return to. And first and foremost on the list is our state health improvement plan. The state health improvement plan I just talked about with the caucus this morning. It has a foundation in health equity and social determinants of health, things that are not solvable only by the health department, things that go across all sectors of government, things that go across all sectors of society. And that's why we have things like a health and all policies working group that we lead across state government. That's why we have a racial equity task force that Susanna Davis is leading, because racism is not something the health department eliminates. It takes a village to do that. And so returning to that state health improvement plan, which goes from 20 to 25, 2020 to 2025, is really important work that we want to get accomplished. And that we already have so many partners aligned with us, because that's how we develop the plan, with their help and input. We also, in that plan, look at 5 core areas. One is substance abuse. One is mental health. Another is chronic disease prevention. Another is oral health. And the 5th is in the big category of child development. And all of those are such high priorities, and they bring us to really the agenda for our health department. So it's the 3-4-50 program for chronic disease prevention. It's working much more aligned with mental health, as we're doing already, especially on suicide prevention and depression. It's continuing the work of our ADAP division, which, by the way, you'll have the opportunity to help us rename probably in the next legislative session, because it's no longer considered in vogue to have the word abuse in a term like that. So we'll have a renaming of ADAP. But all of the work they're doing, we had such success with reversing the inexorable escalation in opioid overdose deaths. And then the pandemic hit, and all of the benefit disappeared big time. So we need to return to where we were. We're recreating our substance use treatment system. It's obviously still the hub and spoke, but we're actually redefining what each of those looks like and what they include, as opposed to just being a system to deliver medication-assisted treatment and some counseling. It's going to be way more expansive than that, which is so critical, because people who have substance misuse aren't defined only by substance misuse, and their success isn't defined only by MAT and counseling. It's defined by everything else: food security, housing security, a steady job that they can actually apply for and get, and then keep. So that's a big item on our agenda. Because oral health has never been profiled and highlighted before, it's now going to be a big deal, and it's a big gap, to be honest, on all of our systems of care. And then we have a constant return to the maternal child health area, because of the fact that we know if we can improve the lives of those mothers pre-delivery and in their first year of their infant's life, we do incredible things to change the trajectory that mother-child dyad is going to go on. And we have some really wonderful evidence-based things that, as you know, we're trying to expand now and continue on. and many things in the adolescent world that have to do with the third space, the after-school environment, that we also are focused on tremendously. Because I am an internist, though, and former Commissioner Monica Hutt and I have worked very closely on this, we are going to pay attention to healthy aging as well, because that has been a neglected part of public health all over the place. And Vermont, I'd like to see us at least have Vermont become what the AARP calls and the WHO call a health-friendly state, and a healthy aging state. And the governor will return his attention to that because he has to sign something to make that start to happen. It's a very lengthy several-year process, but we're a very old state, as you know. We're in the top 3 or 4 states demographically for age. We need to pay as much attention to healthy aging as we do to healthy growing up. So I could go on, but that's as ambitious with my agenda I will be, respecting your time and
So
everything
listen,
else.
thank you so much. This has been very enriching and helpful. It allows us to understand who you are as commissioner and some of the direction that you're taking. And I think that some of the direction that you're looking at is pretty consistent, very consistent with what this committee has been considering. So I'm very glad to hear you talk about the healthy aging piece. And so at one point, we will be looking at our Older Vermonters plan that was started last year with the legislation we passed. I do have a question, as we don't have a lot of time, but I'd like to ask a question and then see if others might have one as well. I'm really happy to see you brought up the State Health Improvement Plan. I've been talking about that recently with Ledge Council, and my question is how you see that plan influencing some of the direction that we're taking with our healthcare reform, and how that plan might inform the the HRAP that's overseen by the Green Mountain Care Board. And do you think those should be integrated in any way?
You know, that's a great thought. I prefaced my
Yeah, I
comments.
always have these great thoughts. See how far they go.
Well, I prefaced my comments with that nexus of health policy and population health and all of that. And this is a prime example. If you recall, healthcare reform, if I could distill it to a very overly simplistic triangle, is the triple aim. And the triple aim is reduce costs. That always goes first because that's what people are most passionate about. And our healthcare system is most out of control with regard to costs. And some of that's through payment system reform. The second aspect is patient satisfaction, healthcare quality, those kinds of metrics, which usually involve delivery system reform. But the third part of the triple aim is the one nobody ever thinks about or remembers, including the government, because they mention it last all the time too, the federal government, and that is population health. And that's exactly what we've been talking about for the last half hour. So if one is really visionary, one can't just say, we can't spend as much money as we've been spending on healthcare, so find ways to cut the budget. And we got to improve the way people practice and deliver care, so work on those initiatives. It's got to be working on these big issues we talked about in the last 20 minutes, which is population health. And realizing, again, that the return on investment is substantial for almost everything I've mentioned. And it doesn't occur 20 years later, it occurs 2 years later. So sometimes even sooner. So that is the message that has to get across. In my first few years, I did meet with the Green Mountain Care Board quite a bit. I have to say that now with the pandemic, I haven't met at all with them. And when AHS is meeting with them, it's very much on the tracks that I've just talked about and not as much on the population health track. And it's unfortunate because even when the feds come to visit us about the all-payer model, they do not integrate as much of that either. I get to mention it, they get to shake their heads, but it doesn't happen as much. The best part of the Affordable Care Act is that it actually forced the US government to spend more money on prevention and public health as part of that act than it ever had before.
Right.
Because we only spend 2% of our budget on it, and it increased it, not to the European level of 10 to 20%, but it certainly moved it in the right direction. So that needs to continue.
Well, you have a partner in the committee, because I think we're all in strong agreement about having prevention and primary care as primary. We'll
Thank you.
continue that. Senator Terenzini has a question.
Dr. Levine, good to see you.
Hi.
Thanks for being here. My wife for the last year, she has watched you faithfully twice a week, and I think she thinks you deserve a daytime Emmy, actually. So big fan of yours here in the Terenzini house. That being said, I posed this question the other day to some folks from the Green Mountain Care Board, and we know that we have a nursing shortage throughout the state, in all of our facilities and hospitals. And in my day job, I'm in regional management and sales and marketing. And I look at a problem like that from a standpoint of marketing and putting together a campaign. In the Rutland region, for example, we have, through the Chamber of Commerce, a marketing campaign that is trying to drive more people to move here and to visit and spend their dollars and so on. So I look at our nursing shortage as an opportunity that we could collaborate to do some targeted marketing and advertising in those areas of where colleges are and so on, to try to attract nurses to Vermont, because we know that we have a problem. I don't know if you're the right person to talk to. Green Mountain Care Board liked the idea, but didn't seem like that was the right platform. But I want to figure out a way that we can collaborate to come up with some type of a strategy to target graduating nurses to come to Vermont, all the benefits that there are of living in the Green Mountain State, from recreation to the health and beauty of our state and so on. Do you have any thoughts on that, or where we could go to really target some of those marketing efforts to get nurses here?
Yeah, I'm not the guy to go to. The guy on the screen is one of the guys to go to, but we are in charge of actually physicians, the Medical Practice Board at VDH, and OPR is actually in charge of nurses and all these other licensees in healthcare. But that doesn't mean I can't have ideas and can't work collaboratively with everybody, because you're right. We have a nursing school, which I think we do pretty well with in terms of getting some retention in Vermont, but it isn't enough to meet the demand. And the numbers of travelers we have, et cetera, is just extraordinary and extraordinarily expensive. It all comes down to, at times, supply and demand and the economic forces that are at play, which is why your talk with the Green Mountain Care Board is important, because there are times that healthcare centers have to spend more on this labor force to compete, whether it's the physician labor force or the nurse or whatever other position you want to come up with. So we do a lot of marketing when it comes to our health ideas in public health. Some of that we apply in other settings, like this labor workforce that you're talking about. We wouldn't be your primary source of assistance in this, but we would certainly be part of the village in the community that's going to take to make an impact on this, for sure. So keep us in mind, but that's not our primary issue. We are, though, very much part of a lot of the rural healthcare federal programs that come through, and they all involve numerous aspects of the healthcare workforce, and often scholarship programs and loan repayment programs that we get involved with, and that you get involved with in the legislature as well, as you know. So I'll try not to say too much more because my boss is on the screen, and I want to give him an opportunity to deal with that question even more so.
All right. Thank you. Good question, Senator Terenzini. I think keep asking it. And Commissioner, thank you so much. This has been a very fruitful discussion. Now, Senator Hardy, you have your hand up. We're just a little bit late. If you have a quick question, I'll allow you to ask it, but I want to bring this to closure. So go ahead.
Thank you, Madam Chair, and thank you, Commissioner, for being with us. I feel like I've seen you more than anyone else in state government in the last year, and I have your voice etched in my head, and that's a pleasure. You have a very calming voice. I don't have a question. Well, I have a question which we probably don't have time for, so maybe you or somebody on your staff could get back to me with the answer, which is if you could clarify a comment that was made in the apparently I didn't hear it, but a constituent reached out to me about the vaccination of college students and what the state's plan is for particularly out-of-state college students who come to college in Vermont. You know, I live in a college district, and it's been a concern of mine all year. So if someone in your staff could get back to me and clarify what your plan is or how you're going to approach that, that would be helpful. And I can save my other question about another population, which is our incarcerated Vermonters, for the next presenter, because I have concerns. Both of them are, you know, people who live in congregate settings and makes them particularly vulnerable. And I've had concerns all along with those two populations. So, but mostly I just want to say thank you for all of your work this year. And I look forward to working with you. We have a lot of good bills coming our way, and I'm sure we'll see you back in here soon. And thanks for your work on the lead bill. Actually, that was the first time I saw you, was that lead bill we did 2 years ago. So
On a different committee. Yes.
On a different committee, exactly. So
Right.
Anyway, just my gratitude. And if someone could get back to me in your department, that'd be great. Thanks.
Yeah, it's a short answer. We want to get to yes in every way, whether it's yes on all college students who come from out of state but are living here, having clinics on their campus, so bringing the vaccine to them. We want to get to yes on all those, but they depend on allocation and making sure we have enough at the time, and making sure the time is the right time, because we know they're going to leave eventually, some of them, for the summer. And it's kind of a race to make sure we have enough vaccine when their age band comes into play to do all the things we want to do. So
Okay.
we all want to get to yes.
Okay. Well, hopefully more information over the next week or two would be helpful for people who are worrying about college students.
Yes, thank you.
Thank you.
All right, good question. And thank you, Commissioner. We will be having a vote on your confirmation. I don't see too many glitches in the way, so you should be hearing from us fairly soon. But thank you very much for being here.
Always a pleasure to interact with you and your committee.
All right, terrific. Take care.
Bye-bye. Good luck, Mike.
Thank you.
Forewarned is forearmed, as they say. You know that. So this is a tough committee to get through, Secretary Smith. And as you may or may not know, Senator Cummings is also on the committee. She's unable to be here because of a personal situation, but we'll follow through, and I know that she'll be interested in following up. Thank you for being here. This is an opportunity for us to listen to you. We've received the letter from the governor reappointing you as secretary. Did I say commissioner? As
No,
secretary.
you said secretary.
I
You're fine.
did, as secretary of the Agency of Human Services. Really, if you would please provide us a little bit of background. And then because the three other members who are here are new to the committee and may not know you as well as I do, but a
Sure.
little bit of your background, some of the challenges that you have faced as secretary, what you have seen to be challenging to accomplish, and then what you see going forward. And I'll say right up front, I'm going to have, if I don't hear, I would like to have you comment on the all-payer model next gen, what's happening, what's coming up in healthcare reform, because that is such a contentious issue right now out in the newspaper world. So that when you get to the future, I'd like to hear a little bit
Okay.
about that. Thank
Great.
you.
Well, thank you, Madam Chair. I did get a threat this morning that somebody would appear and argue against my appointment, and that was my spouse. She was going to try to get into this and argue against it. She claims I haven't seen her in about a year, even though we live in the same house. So that is something that I'm hoping she does not appear. But let me sort of, for those that don't know me, let me sort of give you a brief rundown, and very brief because it's over, 35, 40 years here. Born in Rutland, so I hope I get 2 votes from there, but born in Rutland, graduated high school in Woodstock, out of high school enlisted in the Navy, became a member of underwater demolition team, and then later on SEAL Team 2. Those were there were only 2 SEAL teams in those days. SEAL Team 1 on the West Coast, SEAL Team 2 on the East Coast. Came back to Vermont, got both my bachelor's and master's degree, became town manager of Hardwick, and then left the state for a little while, went to Boston, started with the Mass Municipal Association, which was a sister organization of the Vermont League of Cities and Towns, was a fiscal analyst there, and then went over to their sort of the consulting wing, and then a few of us took that consulting wing and turned it into a private entity and became a partner in that consulting firm in Boston. Came back to Vermont as deputy state treasurer, then left government. You can see in between coming back and getting my bachelor's degree, by the way, to Vermont, I was elected to the legislature from Woodstock and 4 other towns as a member of the House of Representatives. It was fast forward, became deputy state treasurer under Treasurer Jim Douglas, was on left state government, became head of a captive insurance firm, and then came back as Secretary of Administration, and then Secretary of Human Services, and then Secretary of Administration under Jim Douglas. Left state government, took a motorcycle ride for several months through the Canadian province, the Canadian Eastern provinces, and then became state president of Fairpoint Communications, and then did some brief, I hope I'm not missing anything, I may be, but did some brief interim president type, CEO type of work. Was briefly the interim president of Burlington College, and then the interim president of Vital, and now back as Secretary of Human Services. You asked what I've been doing, mostly pandemic since I got here. We had a corrections issue my 3rd week on the job at the Chittenden facility with the women's facility. I asked DRM to come in and take an independent look at that. Shortly thereafter, which was in January, we started hearing about this issue with a virus in China. In February, we were full into preparing for things that were going on, and we've been running ever since. Other things have been going on, the 1115 waiver that you talked about, as well as other things that we are doing. So I'm happy to take specific questions, but let me just start because you did ask on the 1115 waiver. We are up for renewal of our 1115 waiver. There are 2 sort of big 1115 waivers. There's the global commitment waiver, and then there is the all-payer model waiver, which we have to decide what direction we're going in. let's talk with the 1115 waiver with global commitment. That's a big waiver that was frankly established in 2005 when last time when I was here as secretary. We decided to go in a completely different direction on our waiver, and was quite successful. I think most people generally believe that 2005 waiver was one of the most successful waivers that we've ever had from the federal government. It gave us a lot of flexibility, allowed us to use Medicaid dollars in ways that we had never been able to do, gave us a growth cap that was advantageous to the state in many ways. And over the years, some of that has been scaled back through various waivers in terms of what we accomplished back then. Investment cap. Now we have investment caps, and we have an overall cap, and some things are in, some things are out. None of those complications were in the original waiver. It was pretty simple. Most everything was in. And in investments, we could bring in just about any investment we want. Our philosophy is to get back to that 2005 waiver. We won't be as successful getting back to that 2005 waiver as we have been in probably in the past, but getting to many of the elements that we had in that 2005 waiver. No investment caps, just an overall cap, on the budget neutrality cap. More flexibility in what we can use the dollars for, including things like, the areas that they have prohibited in previous sort of iterations of the 1115. So we are looking at getting back to the model of the 2005. Keep it clean, keep it simple. Have a trend rate on our budget neutrality cap that's sustainable, and have mechanisms in place that if we start getting near the cap, we can have control measures that we don't exceed the cap. So those are sort of the things that we're thinking of with the global commitment. The next thing is the all-payer model, and I'm really going to make a big push, I think, on the all-payer model as we start lining that up for discussion, is to get Medicare into the all-payer model. I think it's essential that we get Medicare to participate as freely as we have Medicaid right now. Medicaid is a prospective payment in many respects. We need to get Medicare in that sort of same lineup. We also have to, to sort of look at how we get the providers into this sort of prospective payment model. I'm a big proponent of this. I really believe that prospective payment and not, fee for service is the way to go. I saw it work at the height. I keep saying the height of the pandemic, mid-March, during our first wave of the pandemic, when we shut down basically the healthcare system, and we were able to keep the healthcare system because we could run prospective payments through the healthcare system. I'm a big proponent of that, but I will stop there and take any questions that you may have. A lot's going on in this agency. As you know, this is a big enterprise, $2.6 billion, 6 very large departments. And so I'd be more than happy to take specific questions.
Good, thank you. I do have a specific question. I'm very glad to hear your support of the prospective payment system. I think that has worked. In particular, during the pandemic, we've seen the stabilization fund come through for a number of providers in that way. So, and I guess my first question relates to that. So we're not out of the woods yet. There's no question, and certainly providers are still really hanging on, some of them, by their fingernails, and I include all scope of provider types, from DAs and SSAs to independent physicians, but we've heard recently and very importantly from our primary care docs, and I think that that's a concern. So my question about all of this is, as we're getting more rescue funds, does it seem appropriate to reconstitute the provider stabilization fund to bring people out of the woods, to put the bridge in place? Just your if there are thoughts about that within the agency.
Yeah, Senator, Madam Chair, I haven't given that. It certainly wouldn't be in the magnitude that we had it last time. I don't think if we're going to do something, I think we target. We're very specific on how we're going to do it and how we're going to target. We really haven't. We've been able to continue to use that fund a little bit. We still have some money into that fund, and we've been using it to help various organizations. Lately, it's been really vital in keeping long-term care facilities operating, because once they get hit with an outbreak, we haven't seen the magnitude of outbreaks that we had a few months ago because of vaccination. I mean, it's remarkable what's happened with vaccination, but what we have seen is a reduction in outbreaks. But during that time, there were times they needed two things. They needed operating money to keep going, and that stabilization fund helped them out. And secondly, they needed personnel, and we did a statewide contract with TLC in order to provide nursing personnel for them.
So I'm glad you brought up long-term care, because that kind of leads into another area of concern, and I know I think it's everyone's concern, I would hope. But kind of the base funding issue that we've seen, that we have long-term care providers that have received the same funding per bed for years and years and years. Our nursing homes are just struggling to stay alive. And what thoughts has the agency given to kind of their survival? And then I'll just take it the next step into our workforce, the workforce issues, how to keep our nurses alive and well. And I think you heard Senator Terenzini's question, sort of anticipating that, but maybe talk a little bit about the base funding issues that we have relative to Medicaid, relative to long-term care facilities. We could go on, but how are we going to deal with that?
I mean, our primary objective during this year, when everybody was struggling, from large hospitals to long-term care facilities, was to make sure that the healthcare system, and I consider that broadly, the healthcare system didn't collapse on us. So we provided a lot of funding to various places, and thanks to the legislature for helping us in order to do that. I think what we need to do now is finish getting out of this pandemic, and then looking at the long-term needs, including staffing needs, by the way, nursing, because the person that wanted to come to testify against me, my wife, is a nurse, but her cohort is going to be retiring pretty soon, and that's not to say I'm retiring, by the way, but her cohort is thinking of retiring pretty soon, and we're going to have a shortage. We have a shortage right now, and we need to do something about that. I heard an earlier question from the senator, and I like the idea of trying to provide incentives for people to get into nursing, and trying to have a marketing effort that includes the agency here and others within state government. What we have found during the pandemic if you can collaborate across state government on a mission, you can accomplish that mission. And I think that's one of the things that I would argue that, you know, if we want to put our heads together across state government and with the legislature, we can accomplish doing amazing things, including tackling a nursing shortage. That's not going to happen overnight, but it is going to, we can chip away at it over the next few years.
So, I mean, obviously, our committee is deeply engaged in looking at a variety of areas within AHS. I mean, we cover the gamut. And so there are a number of areas that we could ask about. I will ask a couple more questions, but I want to let the other committee members have an opportunity as well. But sticking for a minute with healthcare, what the thinking is at this point of the agency about the ACO and the agreement that we're updating around the ACO, that waiver, and what the thinking is there.
Yeah, I mean, as you know, we did a major sort of a look at all elements of the all-payer model, including how we can do things better, how the Green Mountain Care Board could do things better, how the ACO can do things better. I think it's critical to keep those elements in place to keep the all-payer model going forward. We think there needs to be changes, and we outlined them in the various documents that we produced on this. And we have, what I have said is we need to make sure that we hold everybody accountable, including ourselves, in terms of meeting the goals that were in that document. And I think the largest thing that we really thought that the ACO, and I think they're going through a strategic plan right now, they need to focus. And they need to focus in order to make sure that they're mission driven, they're entrepreneurial, that they're customer friendly. And I think from what I've been told and what I've been assured, they're trying to move into that direction that we had outlined in the report. I think the ACO is an element that we need to sort of preserve in the way that we're moving. I think, especially with the hospitals and that element of the ACO and the hospital element is a big deal. And trying to keep trying to take risk, I think is an element that we really need to concentrate on as we move forward.
Well, I do want to concur with your thought about the hospitals. The hospitals have been are working hard to have an integrated system of care, and I think it's unusual to see what's happening in our state as compared with what's happening in other states. Doesn't mean there aren't little problems here and there that we'll be taking up. I guess I don't know that you can comment on this one, but the elephant in the room for me continues to be moving the private insurers in the direction that the state is going with Medicaid. And any thoughts that you have had or discussions that you've had with the private insurers on that? I mean, critical, of course, alignment, attribution of lives.
That is a critical aspect of making sure that this works, is aligning the privates, the commercial insurers with what we're doing. To be honest with you, it's something I'm going to need to focus on it over the next 6 months. The pandemic has sort of kept my attention a little bit, and so I do have to circle back on that. But it is not forgotten. It's on my radar screen to circle back and have group discussions with the insurers. The other thing I really want to do is we've got all these databases all over the place in state government, in and I want to start consolidating healthcare information in terms of claims, in terms of clinical data, so that we can really start to focus on where we're going here and how we're doing it in a more methodical way with real data here, and not be pulling data from here and here and here and all over the place. So that's, I don't want to surprise everybody. I'm looking at that very carefully, how to move forward in that area.
Well, that's interesting because I've been looking at the same thing. So and conversations with people who are responsible for collecting and interpreting the data, who don't want to lose that responsibility, that becomes a challenge, absolutely a challenge.
It does.
Yeah.
But it's doable. I think to everybody's benefit, it's doable.
So I do have one little question, but I want to turn it over first to other senators, and Senator Hardy has her hand up.
Okay, thank you, Madam Chair. Thank you, Mr. Secretary, for being with us today. It's nice to see you. I'm looking at I have one specific question, which you probably already know what it's about, which is, I've asked you this in the past, and then I have a more general question. I'm concerned about the sort of stance you've taken about vaccinating incarcerated individuals and the comments you made last week. I understand that you were speculating, and it was unfortunate. And I really think we need to be focusing on vaccinating incarcerated individuals, given the type of place where they live and the specific vulnerabilities of the population because of a congregate setting. And so I don't want to take too much time with this because it's a small issue compared to all of the big things in your agency, but I would like to hear your comments on that. And then my broader question is, looking at the agency's website, you have an enormous set of departments and issues that you have to cover. And it must feel overwhelming, first of all. And I'm just wondering, I haven't quite heard from you your vision, or sort of what your priorities are more globally for those 5-6 departments, and how you're sort of tying them all together in a way that is for the good of Vermonters in our state. So those my specific and more broader question. Thanks.
Okay, let's start with the specific, because I got two things I want to address on that specific question. Right now, we have 199 inmates in state that are eligible for vaccine. 77 inmates have received their first or both doses of the vaccine. 90 will receive a vaccine this week, and 20 next week. We'll have the entire in-state population vaccinated by the end of April. So we are moving forward in vaccinating those inmates, and we're vaccinating all Vermonters, but we're vaccinating those inmates. So it should be done by the end of April. 78 inmates at the Mississippi facility have received their first or second dose of the vaccine. And of course, this didn't get a lot of attention, but I said one of the hypotheses that how virus enters a facility is through correctional officers, and we have vaccinated 467 correctional officers have been vaccinated across all 6 facilities, with 20 field staffs who work in those facilities have been vaccinated. Let me just address because I walk into those press conferences, and when I walk up to the podium, I try to provide as much information as I possibly can. And, sometimes the information that I give is, for example, when Springfield had a refrigeration problem, I knew there were 860 doses. I didn't know all the information, but I thought it was important to get that information out. Now, on the 860 doses, 2 days later, Moderna said it was okay. But I thought it was important to get the information out. There's theories that may be correct or incorrect. And when I was asked the question, what's going on up in Newport, I gave several theories. I gave the first theory, which is it came in through, which is the normal way. It came in through the method that I talked about, through correctional officers coming into the facility. I said there's a working theory, and I don't know if it's incorrect, but we're pursuing it because I was trying to be as open and honest as possible. And that theory is it's being transmitted through mouth to mouth, the diversion of drugs, and that's true. We're looking at it. I didn't think anything of it because I was talking what we're looking at. So I know it's caused some issues with others out there, but when I walk up to that podium, I basically, I try to give as much information about what we're doing and what we're looking at as possible. And I did it in this case. So
I understand that I appreciate that you're trying to provide information. That's what we all want. We want information. I think it's also important to provide accurate, scientifically based information during a pandemic. And I think the concern with your comment was that it speculated in an area that caused harm for people who are themselves recovering from substance misuse and spreading sort of rumors about what may or may not be happening. And it was, I don't want to belabor this because we have other important issues to cover, but I think it's important to sort of strike the balance. And I know as a public official speaking in public all the time myself, sometimes that's hard to do. But I just would encourage you to be especially careful when you're speculating about a vulnerable population.
The other thing that I just want to report is our latest round of testing at Newport facility shows no inmates positive. That came in this morning. So that's good news. It seems like we've got that, hopefully, knock on wood, and this is wood here, I'm knocking on, but we've got that contained. We've returned many of those inmates back to the population because they're medically cleared now. And as of yesterday, I think we had 21 inmates that were positive up there that were still in quarantine. So in terms of that, let me talk about the vision a little bit because I think it's important. There is no other job in state government that I would want, to be honest with you. I enjoy this job primarily because it has a noble mission. And I tell people this all the time, and not to forget this. We are here to help and protect people. There are Vermonters out there that are struggling. And we've all struggled in our lives at one time or another. But many times, and you've heard me say this before, but many times we have family or friends that can help us out. Many of the Vermonters that we help don't have families and friends that can help them out. We are the family and friends. And I want to be that family and friend for Vermonters who are out there. And I want to protect Vermonters like a family or friend would. The vision, I think, is everyone needs help at one time or another. And some people will need help forever. It was just, those with disabilities, those that have certain conditions will need help forever. And we should be there to do that. But we also should be there to help people move on, to be successful in life. And that's what I want this agency to be known for, to make Vermonters successful, both in their personal lives and in their professional lives. And if we can do that, I feel I've done my job. That is where I want this agency to excel at. So that's the overarching view that I have of this agency. You're right, it's expansive. And you think you have it under, something under control, and then something else pops up on it, and you have to, a pandemic comes along in the first time in 100 years, and you're not expecting that. But at the same time, I'm pretty proud of this agency. I'm pretty proud of the people that work at this agency, and I'm pretty proud of the people that we serve, because without us, I don't know what they would do.
So, and just, I want to move to Senator Terenzini, but a comment that making sure that we're a community of care is what I'm hearing, but it also extends right into the agency and ensuring that the folks who work there are also cared for in the same way as their clients. Senator Terenzini.
Thank you, Senator Lyons. Secretary Smith, good to see you. I'll be very quick because I know that we're running over, but you heard the tail end of my question anyway to Dr. Levine. I'm really interested and passionate about finding and recruiting and retaining nurses. We know this is a huge issue from a safety standpoint. We don't have enough. Also from a budgetary standpoint, where we pay $110 to $120 an hour for some travelers. It's killing our expenses and our budgets. So I just sit here and think about, campaigns that we could put together, or marketing strategies to get people to come here, whether it be that we go up and down the East Coast to every nursing school and advertise to juniors and seniors, that we'll buy you a plane ticket to fly into Burlington and come spend a weekend with one of our concierges, and we'll show you the Green Mountain State or something of that nature. But I think we have to get creative, because if you're not from Vermont and love Vermont and know the culture and appreciate it, Vermont might not be the #1 destination for a 20-year-old graduating nursing school from Chapel Hill, North Carolina. So I think we just need to get creative and think outside the box. I don't know whose shoulders it falls on. I'm certainly willing to roll my sleeve to work on it, but we really have a problem. And I hear about it. Senator Hooker and I both live within a mile of Rutland Regional Medical Center, and we hear about this constantly, what a problem the hospitals are facing, the nursing homes are facing, and so on. So we could talk offline or strategize and put our heads together, but it's something that I really want to see us come up with a plan, because whatever we're doing right now isn't working.
Yeah, I'm all ears, Senator, for that. And I'd be more than happy to work with. I mean, we're going to have to be a part of that. So I'm all ears on that one. And by the way, I always refer to it as the new Rutland Hospital, because I was born in the old Rutland Hospital.
So thank you very much. Of course, our committee will continue its work on workforce initiatives, and we look forward to working with you as well. This will sort of end the confirmation hearing that we have. And Senator Hooker has her hand up. I was going to end, Senator Hooker, but do you have a quick question?
Just maybe this is for later, but I'd like to talk about, what you see for social workers and what needs to be done for them, because I know that throughout the pandemic, there's been questions about that. And also going back to the ACO and the risk, and, who should be assuming that risk, and how has that shifted? But those are things that we can talk about as we go into other areas. So thank you for being here, Secretary Smith, and we'll see you again, I'm sure.
I'm sure.
Oh, those are actually two excellent questions. And I know that we'll be circling around to get answers for those, either from Secretary Smith or others. And so thank you again for being here today and sharing with us. You've heard some concerns from the committee and our interests going forward. We will complete our confirmation process probably sometime early next week, and then I'll give our report on the floor to the full Senate. So, but thank you, and thank you for your good work. Appreciate it.
And thank you. And if you get somebody that's in opposition from Westford in this, you'll know where it is coming from.
Well, we know if it's a nurse, we'll know exactly who it is.
We'll see you later. Thank you.
Take care.
Bye.
All
Bye.
right, good. All right, so committee, we have 1 minute before we're to start, but I would like for us to take a little breather, with all due respect to the folks who are waiting to testify. So let's come back in 4 minutes. So just take a 4-minute break, please. So